Well, I think, one of the things that comes up is you need to look at part of the longer term is also you want to look at safety. New agents, you want to make sure as you observe people for longer periods of time, you're not getting the safety side effects. There's the issue of if a drug has a long biological activity, even though we say the same thing with inclisiran, you like to get as much safety data as possible. So this trial gives us more information in regards to sustained safety and efficacy. It's still going to require a larger phase 3 program to give us really, what you like to look at is a larger sample size, and it's both the number of patients and the duration of therapy. So there's an open label extension ongoing for the APOC3 program to accumulate even more safety data. And this is always a very important approach when you're getting into, basically, it's a pretty exciting area we have in terms of biotechnology. However, there's always the unknown. So you need to get, the trials are a little bit longer. You have to have pretty substantial numbers so that you can get an idea really of both the benefits and also of the potential risk of a therapy.
So IMPROVE-HCM is the study evaluating ninerafaxstat, and it's a phase 2 study, okay, which means that the predominant goal is really to look first and foremost at safety and tolerability of the drug. But as well, we looked at a number of different clinical efficacy measures, including that of exercise capacity by cardiopulmonary exercise test, and also heart failure symptoms, okay, as measured by Kansas City Heart Failure Questionnaire, okay? And so what we found was, first and foremost, that ninerafaxstat in a population of non-obstructive HCM patients, and by the way, the population of patients that we were looking at, in order to be in the trial, you had to have objective evidence of exercise limitation, okay? So less than 80% for peak VO2, okay? So within that kind of symptomatic, non-obstructive population, what we found was that ninerafaxstat, first and foremost, was very well tolerated, okay, and therefore generally safe, okay. In terms of clinical efficacy, what we found was that first and foremost is that ninerafaxstat improved exercise capacity as measured by ventilatory efficiency. So there was an improvement in the cardiopulmonary exercise variable of ventilatory efficiency that was enhanced with ninerafaxstat compared to placebo, demonstrating that ninerafaxstat was able to improve the performance of exercise in patients with non-obstructive HCM. Yeah, and the second big thing as well to complement that is that for those patients that were most limited by symptoms at baseline, treatment with ninerafaxstat improved symptoms in those patients by demonstrating a significant improvement in the KCC score of 9 points, essentially, okay? With a change, by the way, of 5 points, usually considered to be clinically meaningful, okay? So essentially, to kind of summarize that up, ninerafaxstat, well-tolerated, but as well demonstrated an improvement in exercise capacity and also an improvement in symptoms.
I truly feel fortunate, and I say this in clinic all the time. I say this to colleagues all the time. I think I said it last night to one of the fellows. Like, I feel so fortunate to be in this space at this time. I think that, it would have felt very different 30 years ago, 40 years ago, where we were really just, and even 5 years ago, when we were really, right, we were really just stuck with medications that were devised for other disease processes, and we were using as, ways of mitigating symptoms to try to improve day-to-day quality of life. Whereas now I think the tools that we have seem to have fewer day-to-day side effects, so affect day-to-day, quality of life less poorly in terms of the side effect profile of the drugs, like other medications, beta blockers that can really cause a lot of fatigue, sexual dysfunction, things that can be really important and life-altering. these medications don't seem to do that, and also offer all of this benefit in terms of actually reducing the burden of the disease in and of itself. I think it's not just about the myosin inhibitors. There's a lot of work and thought that's being put into the SGLT2 inhibitors and whether or not those can be disease modifying. There are a lot of people thinking about and trying to understand, the same way that myosin inhibitors were developed. You have to understand how these genetic abnormalities then result in proteins that have malfunctions. And if you can understand the malfunction, then you have a way to target that malfunction and try to correct it. And I guess that's the most exciting thing to me about this whole disease process is if you think about, the work that the Seidman lab did and, leading up to their discovery of the first genetic change that's responsible for HCM back in the 1980s when I was in elementary school, and where we are now, that is all led from the work that was initially started, and just thinking about that stepwise process. It's really the process of scientific discovery and then turning that over into how can we help is just really fascinating for me to witness. That was very long-winded, but that's truly how I feel about it.
So you've set the bar very high for yourself. You've designed a pragmatic trial. You have enrolled patients that have had excellent standard of care, it seems, have undergone prompt revascularization or on excellent background medical therapies that have been shown to reduce these target events. What were the primary results of IMPACT-MI?
Yeah. So the primary endpoint, just to remind you, was time to first heart failure hospitalization or all-cause mortality. We did not reach our primary endpoint. There was a 10% relative risk reduction in the primary endpoint that was not statistically significant. P-value was 0.21. Now, when we dissect the primary endpoint into its components, there was no signal of mortality benefit, but there was a 23% relative risk reduction, statistically significant, in heart failure hospitalization. And then we had also pre-specified total heart failure hospitalization, first and recurrent combined. And that was 33% relative risk reduction, also highly statistically significant. So not only directionally, but even the magnitude of benefit in the 25 to 30% range is very consistent with what we have seen in patients with diabetes, in patients with CKD, and in patients with heart failure, regardless of diabetes and regardless of EF. So in that sense, the story is pretty consistent. The discomfort you have here now is that the primary endpoint is negative and there's a component positive, but it's not sort of you just squeak by. It's pretty positive, 25 to 30% relative reduction. So how do you sort of interpret it, or what sort of sensitivity analyses that were done? So I'll mention just a couple. We did, as you might imagine, we have done a ton of analysis and all sorts of definition, and the data were consistent. But the two that I would mention to you is that outpatient heart failure was not collected as part of the primary endpoint because you were trying to do a pragmatic trial. But what's interesting is that a serious SAE of heart failure was collected that had three components: heart failure hospitalization, death due to heart failure, or outpatient heart failure event. So the site could notify out failure event as an AE. So that was collected. If we now include that in the endpoint, so 23% time to first, 33% total. If you include outpatient heart failure event, there was a 37% relative risk reduction. But also in our primary endpoint, more than 50% of the events were mortality events. If you include the outpatient event, our sort of exploratory made-up primary endpoint of all-cause mortality in total heart failure event was statistically significantly positive. So I think there are some sort of these issues. So then we said, well, what else can we do to pressure test our results? So remember I said in the beginning that we collected data on medications for the first 6 months. So we said, well, one surrogate could be that you have been started. So, we have a discomfort that this outpatient heart failure is a SAE. So what exactly does that mean? Well, why don't we correlate that with initiation of heart failure medications in the outpatient setting? All 4 analyses we did: new ARNI use, new RAS inhibitor use, new MRA use, new diuretic use post-discharge. 25 to 30% higher in the placebo versus SGLT2 inhibitor empagliflozin arm. So we are sort of getting all of these signals, data come together. Now, again, I mean, we can argue heart failure is the biggest cause for mortality. Like, why isn't mortality signal? So maybe we can get into that. But these are sort of the overall results.
I think Danger Shock was an extremely important trial, really well done, and answered an important question. There was a lot of controversy out there whether left ventricular support, in this case, a microaxial pump. I'm going to say the brand name, it's the Impella CP. You have to, otherwise it's hard to have the discussion, whether it was really adding benefit or not in the setting of cardiogenic shock or high-risk PCI. Controversy in both settings. Certainly what data exists show a higher rate of vascular complications and other complications, bleeding, etc., than a balloon pump. However, a balloon pump itself, the data have never really been clear, have provided unequivocal benefit in those settings. But the problem is, if one looks at real life, well, you have to throw in a balloon pump when a patient's crashing. You have to put in an Impella if a patient's doing poorly. Which one you pick, it depends on a personal preference and maybe the patient and all sorts of different factors, some scientific, some unscientific. But what we really lacked was great randomized clinical trial data for Impella, and now we've got it in the setting of shock after STEMI. And what it shows is a lower rate of all-cause mortality. So even though it's not a blinded trial, you can't blind these sorts of trials, at least you can't easily blind these sorts of trials, the fact that it's mortality, that's a pretty pure endpoint. Doesn't mean there couldn't have been other things going along with the Impella, other patterns of care that also ended up influencing the outcome. That's always a possibility, in these sorts of trials where there's no blinding. But nonetheless, mortality, very hard to argue with. And it does seem to make sense, at least in my own clinical practice. I certainly had patients where I felt, rightly or wrongly, but I felt, pretty convinced that the Impella saved their life. And I'm talking about high-risk patients such as STEMI and cardiogenic shock. I've also seen some pretty serious complications, in particular vascular complications and bleeding complications, the occasional stroke as well. So, I felt a randomized clinical trial was necessary. I always felt we should have done one in the U.S. years ago, but I'm glad finally that investigators have stepped up and done this trial, and I think shown pretty clear benefit of the Impella. So to me, this should be a practice corroborating trial, because in the U.S., I think most folks were already doing this, but they were doing it without data, or a device, as I said, that is associated with complications, does have financial costs that are substantial, but with a reduction in all-cause mortality in a patient population where it's really hard to alter mortality, cardiogenic shock, I think this is a big advance. And moving forward, I think in addition to primary PCI and STEMI, that the Impella will have a major role as long as patients don't have contraindications to its placement. That is, no problem with respect to vascular access and an adequate caliber of the femoral arteries, no issue with known left ventricular thrombus. So, things like that would preclude its use. But in patients who are candidates, which I'd say is a majority of patients with STEMI and cardiogenic shock, I had been using Impella, but now I would use it, with pride and joy, and a sense that I'm actually doing the right thing and not just rolling the dice, hoping it's the right thing. So great trial.